to ask me, does low-dose naltrexone kill cancer cells? I would say it supports the actions of your classic cancer-killing drugs, such as your platinum, such as your radiation. These drugs and these modalities do work, and they work well in a lot of patients. However, there's a small fraction of patients that don't respond as well. And what low-dose naltrexone can do is that it can open up to these patients that are non-responsive the whole idea that yes, you can use these treatments in your case, which I think is fantastic. And if you were to say, do these patients see that as a cure to their cancer? In that situation, you must say it's helped them, and that help it's given them means the world.
I had a patient who I really thought with advanced cancer should be progressing, and was delighted and surprised that she hadn't progressed in a certain time. And I asked if she was taking anything else that I didn't know about, because lots of patients do take all sorts of things. And she told me she was taking low-dose naltrexone, and this is well over 12 years ago, if not longer. And I asked her where she got it and the whys and the wherefores. And I learnt she was getting it from Dr. Bahari in New York, and she told me a bit about the background and said that I should go and visit next time I was in New York, which is essentially what I did. And I realised he came from a proper clinical background, that he had been a narcotics expert and weaning people off morphine, heroin, which is how he knew about naltrexone, and had been convinced that at low doses and not at high doses that a lot of chronic conditions seem to improve. So that's how I got interested, and I became more interested in it, that it might have a role in cancer, when I noticed that other patients were doing very well on it. And in the end, that often when there were no therapeutic options, I started prescribing it myself and being impressed that there seemed to be more to it than a placebo or smoke and mirrors, which is what many doctors regard something at low dose. Well, what really excited us is that I've taken the clinical observations from this seriously, and because some of the results I saw have been really quite remarkable. For instance, I had a patient who had very serious melanoma of the head and neck, and he'd been on a vaccine program for about 4 years. And when he started to progress, he wouldn't take any chemotherapy, but I did discuss with him about my suspected properties of low-dose naltrexone, and he did agree to take that. And rather than be grateful for taking the low-dose naltrexone, he came and complained to me 2 weeks later that he had broken out in vitiligo, which means you get white patches all over, and often just in the arms, sometimes subtly on the face. In fact, about 5 to 8% of people have some form or other of it, except this appeared quite dramatically a few days after taking the low-dose naltrexone. He didn't like the cosmetic aspect of it. I basically said I was delighted because it was a sign that the immune system was responding and had targeted the melanoma, and that's exactly what it is due to. The killer T cells recognise a major component of melanoma, and the normal melanin's taken out and bystander, a friendly fire, as it were. Well, he is still here. I mean, it's had a dramatic clinical response to this. And what that showed me was that low-dose naltrexone had to be stimulating part of the immune receptor pathway, and that was the start of our research. I said to the guys in the lab, this drug isn't just working through opiate receptors, it's working through an immune receptor pathway, and we sat down and worked out how to do it, did a strategy, and actually hit gold when we found that a very important immune pathway was indeed being heavily interacted with by low-dose naltrexone, which explained the clinical observation I'd seen. With vitiligo being switched on, there's no defined time period. It can occur at any time. But with an effective immunotherapy, this usually takes some weeks, months to occur. And we found that with the new checkpoint inhibitors, we basically don't really look to see if you're getting a response for a couple of months, because it is that slow. So the fact that the vitiligo was induced very quickly suggested it had just flicked that switch which was already programmed. But the vaccine hadn't done it. For 4 years the vaccine had not done it. It just took LDN and it flicked it. Well, obviously we're going to be very focused on researching it, doing it properly. I mean, LDN's been used anecdotally and off licence for a long time. There's fantastic results out there, but in order to take this forward, really want to put it into proper clinical trials, get the right niche, and because there's so many possibilities, we would like to do everything properly, get it properly approved by the FDA, EMEA, etc., and then go for a condition that we know the chances of it working are very high and don't take very long. And of course, two of the conditions it's effective in, multiple sclerosis and Crohn's, are very, very difficult studies to get approval for. They're very, very hard and expensive trials to do. And you mentioned about taking it with something. This is what we found with all immune modulators, that they're much better in combination with other agents than by themselves. And one of the things that we have been researching independently, and it fits beautifully, is that the great, what I would call, endemic epidemic of low vitamin D in the population, and particularly in the winter months and the further north you go. And this is one thing that we have been looking at very carefully, because we think that there is a positive interaction here. But that's not a big surprise, because if you're low in vitamin D, you don't respond to a whole range of things, and chemotherapy, whatever. So that's one particular thing. Combining it with other immune modulators stroke vaccines is the next obvious way to go, as is enhancing the anti-inflammatory aspects of it. So all these things we'll be looking at in our research, both in the lab and taking it forward into the clinic. Given how non-toxic it is and how relatively cheap it is compared to other interventions, could be applied to, I would say, the vast majority of people who have uncurable cancers, whereas you can't cut them all out, because the anti-inflammatory aspect for most cancers is now well established, and the need to boost the immune system when you have a cancer. In fact, one of the pieces of research that we did early on, I'm most proud to have done, and that we showed that even patients with very early colorectal cancer have a major suppression of the immune responses, and we proved that this was due to the bowel cancer of the patient group we used, because we repeated the assays a month after the tumour had been completely removed, and the immune system all bounces back into the normal range. So after that, and colleagues elsewhere showed that they got the same sort of thing with other solid tumours, lymphomas, gliomas, etc. So it means that tumours immune suppress, and if you can't cut them out, you want to go some way to correct it. There's some very many fancy, toxic, expensive ways of doing that, but low dose naltrexone does a lot of those properties, provides a lot of those properties without any of the toxicities, etc. So as a universal supplement as well, to be an anti-inflammatory immune booster, I can't see why it would be limited to any particular tumour type.
Low dose naltrexone works on a number of processes in cancer cells. So if a patient has a cancer at whatever stage, if that cancer exhibits the same malfunctions, the same profile, for want of a better term, that naltrexone prefers, or low dose naltrexone likes, then you should see some kind of responses.
Right, the first thing is that there's no drug in the world, and that would include LDN, that is active in everybody. But LDN, if you basically got advanced cancer and you basically don't want to take anything else, but you're happy to try something that might help you feel better, static disease, then to my surprise, I've seen that LDN is very effective in that scenario. As I was saying, it shouldn't be looked upon as a cure going to work on everybody, but I'm impressed with people who have their diseases stable after finishing chemo, having given up, and they take LDN and they feel much better on it, and they request, and it's the repeat the request for repeat prescriptions that basically provides the evidence that they're doing really well just on this treatment.
One thing we did first of all was to explore the effects that low-dose naltrexone had on immune cells as well as on cancer cells. And I suppose one thing that people tend to forget is that drugs that you give to patients will have an effect on immunity as well as on cancer cells. So these so-called indirect effects versus the direct effects. And the beauty of naltrexone, especially at low doses, is that it can have an effect both on the cells in your body as well as on the cancer cells. So it's like a double-edged sword, I suppose. One edge that kills the cancer directly, and one effect which modifies the body's own natural ability to kill cancer cells. So this drug, naltrexone, being a botanical agent, or at least a semi-synthetic, we could then explore that further. And we showed that in addition to the effects on immunity, which made it a fantastic stimulator of immunity, which allows the body's cells to be re-educated to re-engage cancer cells. Low-dose naltrexone was also capable of targeting cancer cells directly. How does it do that? And that's the exciting thing. There's lots of data to suggest that it binds to certain proteins on the surface of the cancer cell, and in doing so can manipulate the cancer cell to make it much more sensitive to treatments. There's also other trains of thought that suggest that it might enter the cell independently of these receptors. But nevertheless, what we're finding is that the mechanisms that controls cancer, the mechanisms in fact that makes a cancer cell is being turned off. It's been tweaked in such a way to make that cancer cell much more sensitive to cell death. So if you were to go along or come along treating patients with low-dose naltrexone, in addition to other drugs which are focused on killing, then we have a fantastic partnership where one primes the cell whilst the other does the killing. And that's what's exciting about low-dose naltrexone.
So it was in about 2007, 2008 that I first discovered LDN, and we started using it immediately as a cancer treatment because there was some promising data presented by Dr. Bihari. So when we started using LDN for patients with stage 3 or stage 4 cancer with low disease volume, in other words, small tumors or patients who had had surgery already but were not completely cured, we started seeing better results. One of our earliest patients that we used LDN on was a 65-year-old gentleman with bladder cancer. He had a tumor in the bladder which was treated by conventional means, which means surgery. So they would go in and remove the tumor. They would burn where they had removed it from with a cautery, and inevitably the tumor would return some months later. So this gentleman had a few surgeries, and the doctors had told him it was an aggressive type of cancer, which is called high grade, and that because of the depth of the growth of the cancer into the bladder wall, it was growing into the muscle, they felt that he was at risk of the cancer spreading in a short time. So this fellow was offered aggressive surgery, which meant removal of the entire bladder, and he declined that. At that point, he came to us, and we started him on LDN, and he did very well on it. He had a little bit of sleep problem, but that was easy. We just gave him a little sleeping pill with that, and he did very well. And at the same time, his conventional doctor gave him a single course of an immune therapy called BCG. It's a bacteria that they instill into the bladder, and it can trigger an immune response. So while he had the one course of BCG, he was on LDN, and he took LDN for about 4 months, and then he had gone back to see the surgeon. They took a look in the bladder. The cancer was completely gone. So this gentleman continued LDN for about a year. He had no further conventional therapies, and the cancer remained in full remission. And it's been about 7 years now, and this gentleman is still in full remission. So in his case, he did extremely well, and I believe that the LDN and the immunotherapy worked in unison, and one synergized with the other in order to give him an excellent result, which in this case would be considered a cure. Another one of our earlier cases that really intrigued me was a 58-year-old gentleman that came to see us for a rare cancer that was present in the base of his tongue. He had about a 3-centimeter tumor in the tongue, which was an adenoid cystic carcinoma. That's just the type of cancer, but it's an unusual type of cancer of the mouth. So this gentleman went to see his specialist, and he was told that in order to cure his cancer, the entire tongue would have to be removed surgically. And because of the location, in order to really give him the best chance of cure, they would have to remove his voice box as well. And then there was discussion about possible chemotherapy and radiation after all that surgery. So naturally, this gentleman was upset because of the dramatic change in his quality of life that would follow after cancer treatment. So he declined conventional therapy. He came to see us requesting a therapy that had no side effects. So the first thing I told him was that there's no such thing that has no side effects. However, immediately I thought of LDN because it's one of the gentlest therapies I know. So he ultimately started LDN, and he combined it with vitamin D because that's considered to be a medicine that can potentially enhance other cancer therapies. It can work on the immune system and improve anti-cancer immunity. Vitamin D can also change the behavior of cancer cells into a more harmless behavior so that they don't grow and aggressively spread. So this fellow started taking the treatment with LDN combined with vitamin D, and within a few months he felt that the tumor was shrinking, and so he continued therapy. We didn't hear from him for a while until about 2 years after he started treatment, and he sent us a new MRI report, which is a scan of the tongue that showed complete disappearance of the cancer. So he continued on LDN and vitamin D, and he is now over 5 years cancer-free. His specialist is quite surprised and pleased to the point that he no longer repeats his scans frequently, and he just sees him once a year for a regular checkup. A couple of years ago, a 53-year-old gentleman came to see me requesting treatment for a bowel cancer. It's present in the sigmoid colon, and it was believed the cancer formed as a result of his inflammatory bowel disease called colitis. So this fellow was offered surgery by his specialist. That would have been the standard treatment and potentially curative. However, he was afraid of surgery. He was afraid of the complications. So as a result of his concerns, we offered him a few treatments, and he ultimately chose LDN. So he started LDN, and we were monitoring him with a blood test for colon cancer called CEA. And in addition, we also monitored him with colonoscopy. So his specialist would have a look within the colon and see what was happening with the tumor. It took about 4 months to see some improvement. We actually started to see the CEA, the cancer blood test number, fall, and it was falling progressively over about a period of about 3 to 4 months subsequent to that. And then it was maintained at a steady value, about 30% below the original value. In addition, he did have a follow-up colonoscopy, which confirmed that the cancer was stable or smaller, and his symptoms of bleeding in the bowels actually improved as well. Now this fellow did decline traditional surgery, which was not exactly what I had recommended either, because I thought that the cancer could potentially be curable. However, the case does demonstrate that in cases where, let's say, a patient refuses surgery, or if surgery were to be too risky, then LDN could be an option for a patient to try, especially if the cancer is non-aggressive. In addition to using LDN, we almost always recommend vitamin D. The dosing of vitamin D is very controversial, but there's adequate research now that supports using high doses of vitamin D. So that's what we're doing. We're using typically in the range of 5,000 to 10,000 units per day of vitamin D3, preferably in liquid form because it's easier to take, and so patient compliance is high. Sometimes we even need upwards of 15,000 units or 20,000 units of vitamin D per day. As an aside, I personally take 15,000 units of vitamin D myself, and I've been taking that for about a year now. I take it for my allergies, and I find it to be highly effective.
So I became acquainted with naloxone and naltrexone, the drugs, in my training over 20 years ago in emergency medicine. And early in my career in general medicine, began to explore the use of low-dose naltrexone for a variety of illnesses, including autoimmunity, pediatric disease, and then cancer. As the years of practice went on, we developed more and more cancer patient care where we were using the low-dose naltrexone as an integral part of the patient's therapy. We began adding low-dose naltrexone with a variety of cancers, not knowing for sure which ones would be more or less responsive. And back at that time, the data was very sparse, so we were basically asking patients if they were okay with us trying it. Many would come in with articles they had read, and we would start the therapy with them. We have had a number of responses that run the gamut from stabilizing disease to being very supportive of other therapies that were being done, both natural and standard chemotherapy and radiation in some cases. And then one of the most beneficial uses we have seen is in the patient who has come back from the oncologist and there is the report, there's no more we can do for you. So we use it in our program for stabilizing those patients where standard of care has run out. I think the persistence of our using the low-dose naltrexone as a therapy is owed to the fact that we see positive results frequently enough that we keep using it. With many therapies that are non-standard, you'll find that they work in a very narrow margin or for only certain types of cancer or certain types of illnesses. And so we'll reserve those for those certain type things. Low-dose naltrexone at this point, as I say, 8 or more years, has impressed me enough that I keep it in the beginning treatment when I'm working with patients almost across the board with cancer. So the results are quite varied. We have had some patients, especially elderly patients, where they're very sensitive to medications. They've been told by their oncologist that they are not a candidate for standard therapy because they're too elderly or frail. We have had a few of those patients where their disease, their cancer has stabilized with basically the addition of low-dose naltrexone on its own. We don't expect that in everybody, but it's been curious to me to see one agent do that in cancer, which is very unusual. Most people, what we see is it is a very good synergist with the rest of care, and sometimes what will happen is a patient will stop taking it and not tell us. They'll come back and they'll have some regression or some addition of symptoms from their cancer. We'll find out they've gone off, they'll go back on, and often those symptoms will go back away. So we do see it as an integral part of care. I would say the number of patients with cancer that we have prescribed low-dose naltrexone for in the last 7 or 8 years amongst myself and my colleagues at my clinic would probably reach a number between 250 and 350 patients. As I said, we've seen a wide spectrum of response, all the way from it was the only thing that they could tolerate due to age or frailty, and we saw a stabilization of their disease, meaning it didn't progress, which is a very positive finding, to the person on multiple therapies where it's being used as part of a team approach. And as I mentioned, it being withdrawn caused a reversal of the positive. So I would say in at least 30% of people, we have some verification either based on it being the only drug used or it being taken away from their therapy and them having regression that we could really point to a clinical success. The rest of the patients, it's not that it made or broke their therapy, but we definitely left it in their therapy and never withdrew it to see if that was part of the success or not. But we definitely have seen, and as I say, with either on standard oncology or natural therapies, I've seen it be useful and positive in cancer cases more than most other therapies I've used. I would say that of all of the integrative and standard therapies that I have seen, both in chronic illness, but especially in cancer in the last 20 years, low-dose naltrexone has been one of the top treatments that has impressed me as far as outcomes, improving quality of life, and stabilizing disease. For patients, it's largely letting them know that it has a very low incidence of side effects and downside, and the most we can do is share case reports with them that match their cancer, and normally we have some positive ones. Of course, you can't guarantee anything in cancer, but to me, it's low downside, low cost, and a high value therapy.
So low-dose naltrexone isn't a cure to cancer, unfortunately, and I suppose there's no such thing as a true cure to cancer. But what low-dose naltrexone will do is it will support the actions of other drugs that are out there which have been shown to have an effect. For instance, chemotherapies are efficacious in lots of patients, but they could be boosted. Irradiation is also effective in lots of cancers, but again, they can also be improved. And these agents that can support the activities of other drugs, these so-called adjuvants, is a class of agent that low-dose naltrexone will sit in, which makes it an incredibly exciting piece of compound. So what we did, by being armed with all this genetic data, we went on to see if these cancer cells that we brought into the lab could be sensitized or could be affected upon by naltrexone. So we used in vitro experiments, so experiments performed in the lab to see if we could kill these cancer cells. And the disappointment was that by using naltrexone at low concentrations continuously, we were having no effect on a number of cancer cells. However, the genetic fingerprint told us that it should work. So by changing the entire schedule, changing the way that we gave this treatment to the cancer cells, based upon our understanding from the genetic fingerprint, we could actually cause these cancer cells to undergo cell death. So to summarize all that, we have a situation where if you were to use low-dose naltrexone continuously, you'd have no effect, or the effects would be minimal. However, if you were to use a schedule that involved slightly different aspects, you would end up killing those cancer cells. And that's something that, armed with, we can take forward to the clinic and convince clinicians to start using low-dose naltrexone. Not on its own, possibly in combination with other therapies, such as these chemotherapies, as I alluded to, as well as other newer drugs, such as the immune therapies. So the results of our studies have allowed us to understand the action of low-dose naltrexone much better than we did a while ago. And armed with this knowledge, we can design new treatment regimens, these new different strategies that can be used in patients. And in that regard, it's a game changer. We now know how best to use naltrexone. In the past, we used to think naltrexone should be used continuously, and that would induce some effects in a number of patients. However, the data that we've generated very recently suggests that we can actually improve on that. And it's these small step changes that will lead to a situation where these patients with cancer will benefit. We've worked on a number of cancers in our lab-based studies, and these cancers have involved cancers of the colon, of the breast, and also of the lungs. And in these cell lines, we've shown that the effects of other drugs can be enhanced by using low-dose naltrexone, and we're yet to find a cancer that doesn't respond in this positive way. But we've only just started very recently, and in the 3 cancer cells types that we've used, we've had a response that's always been positive. Our results suggest that doctors who prescribe naltrexone need to be very wary of the way it's given. We've shown that depending on how the drug is given, you may get responses that are not optimal. Indeed, our results specifically showed by giving this drug continuously over 4 days would result in effect, although good on its own, was inferior to if you were to use the naltrexone on a different schedule altogether. What our data suggests that low-dose naltrexone, the effects of low-dose naltrexone can be improved if you were to modify the schedule to involve breaks in treatment. My hope for low-dose naltrexone is that it's incorporated in treatment regimens, in treatment strategies in patients with cancer. Naltrexone, especially a low dose of naltrexone, will enhance the actions of a number of chemotherapies in a number of cancers, and my hope is to see it being included in treatments.
Well, you know, in a word, with the findings that we've captured here, showing these was really unexpected without these closely observed clinical observations of various patients. It gives a complete scientific justification for taking this forward into the clinic and giving evidence to the clinicians and the regulatory authorities and say, look, this does this, that and the other. It should be incredibly useful in these conditions, and here you have this enormous amount of anecdotal evidence that it is. So basically we want to go forward and capture it so it can actually be used and prescribed in the clinic on the NHS.
Our data gives us a better insight into low-dose naltrexone. By better understanding low-dose naltrexone, we can better understand the ways that you can treat patients with cancer. And so I suppose the take-home message would be we need to know how this drug works to maximise its uses in cancer patients. Patients are not patients are not interested in whether the drug or how the drug works. They're more interested in whether or not the drug works or not. What our data suggests is that we have a better understanding, and by understanding the drug better, we can design better treatments that will benefit patients.
Well, the NHS and the government say, and the various people say, that they would basically like drugs which are non-toxic, cheap, and cheap inverted commas. The current drugs being used to treat cancer are coming in at an average of about £5,000 a month, and when you finish one, and there's another one. So these costs are totally unsustainable. Whereas the advantage for a drug like this that's cheap, non-toxic, can extend life possibly. We don't know till we try that, but you can see as a doctor, it does improve the quality of life in a lot of people. That's an enormous potential that could save, I believe, you know, millions in other treatments that we currently use to try and improve the quality of life and extend, etc.
One of the issues with LDN being a generic drug is that if it has been proven to be effective as a treatment for a disease like cancer, it could certainly prove to be challenging for the pharmaceutical industry. The reason is that this very cost-effective medication could potentially compete with branded drugs that are out there already. So I think that there is going to be a bit of a challenge moving LDN forward as more of a mainstream therapy, because it will likely be opposed by the pharmaceutical industry. Well, at the current rate of growth of cancer around the world, and looking at the cost of cancer therapies right now, it's pretty clear that in a short number of years, the treatment of cancer is going to be unsustainable. So we actually desperately need more cost-effective therapies. Now, with the current research model, there's really no motivation to conduct formal, large-scale clinical trials with LDN because it is not a profitable drug. So what we really need is a different model for researching LDN, one in which there should be probably input from the government in order to fund large-scale trials to finally put to rest the idea that LDN is in fact a valuable therapy. And potentially from the insurance industry, there should be funding because they're probably going to benefit greatly from the reduction in cost of cancer therapies.
Low-dose naltrexone increases what's called OGF and OGF receptor. These are little peptides, basically proteins, that when connected together inside the cell, they give a signal to the nucleus that inhibits the cancer cell production. the amazing thing that they found is this is present in 90% of the human cancers. Over 47 different lines of cancer, they've shown that this mechanism is present. And after reading their papers regarding this, I found the science to be good enough to be legitimate to try for people who have cancers that really have no other choice, stage 3, 4 cancers that really are done with their therapy. It also increases what's called the P16 and P21 pathways that are the key components to inhibiting the cancer cell division. And what they found, interestingly enough, is in the cancer cells, they don't have a lot of OGF and OGF receptors. So what it does is it boosts the body's own way of inhibiting cancer cells. We don't know that it really destroys tumors, it just inhibits cancer cells from dividing. So in doing so, I took it upon myself to do research on it before I would use it. You know, I'm a scientific type of person and like the science to be there. Dr. Zagan published articles regarding ovarian cancer cells specifically with naltrexone and OGF. And since ovarian cancer is the 4th leading cause of cancer mortality with women, and it's the leading cause of gynecological cancer, this is a tough cancer and very critical to understand the cancer mechanism. And they found that the OGF receptor mechanism was present there. They showed it reduced the cancer cell proliferation. And he's had a number of other articles showing the same thing. So I have a patient who in 2004 had initial ovarian cancer. And as Dr. Zagan points out in his article, 65% of the patients with ovarian cancer recur within 2 years. Well, she went 6 or 7 years, and then she had stage 4 metastatic ovarian cancer everywhere. Her spleen, liver, colon. She had the surgery, she had some chemo, and then she heard about me through a friend, and so I started her on low dose naltrexone in 2011. And as a matter of fact, I just talked to her 2 days ago. She's doing very well. Her liver metastases have stabilized, and she's now in a stable state. And this is for 4.5 years later, which is significant because I was anticipating that she wouldn't have lasted more than 4 or 5 months with metastases through her whole abdominal wall cavity and the other areas I mentioned. I had another patient who, at 38 years old, had discovered that he had stage 4 squamous cell carcinoma of the tonsil. And he was treated with the usual chemotherapy, radiation. He elected not to have a radical neck dissection. He just said, I'm not doing that. So about 8 months goes by, and he's just not doing very well. He was tired, fatigued, and so I said, well, come to my clinic. I did a bunch of body chemistry tests, hormone levels, and found that the chemo and radiation destroyed all those, which is very common. Once I got those balanced, he was feeling better now, and he's doing great. But I also put him on LDN. And squamous cell carcinoma of the tonsil does not do very well when you're stage 4. This is 4 years later now. There's no signs of cancer. His oncologist says we really don't even have to follow the PET scans anymore because there's really no evidence of anything recurrent. And he now is doing very well. He's doing worldwide trips, working 2 jobs, and he takes the 4.5 milligrams every day and hasn't had a problem since. In regards to how well he's done, well, maybe half the people last 5 years with that diagnosis. He met 2 other men who had the same diagnosis, same exact diagnosis when he was at MD Anderson. They have now both passed away, a couple of years ago. So that, as long as he lives, it's another telling sign that LDN can be very positive for people, long term, in maybe preventing the recurrence by inhibiting any other cancer cells that are residing or starting to arise again.
I'm a stickler for facts. I want facts. I want proof. I want black and white. I want to know this is how it works. It increases the endorphins in the body. We know this. What do the endorphins do to the tumor cells? They block those tumor cells, and they block the receptors on the tumor cells. They cut down the inflammation around these tumors, because this inflammation around the tumors helps it to grow, helps to get blood vessels to grow out of those tumors so you can get more metastases, etc. So low-dose naltrexone plays a role directly there at the tumor surface, at the tumor cell. However, it has another mechanism. This is what's also fascinating, and that was, as I said before, it downregulates some of the T suppressor cells, the ones that are the most important in suppressing the immune system. It blocks those so the immune system can go up. And you can get the immune system up by downregulating these T suppressor cells. It's called FOXP3 for those who are in biochemistry or studying this area. The FOXP3 cells are blocked by low-dose naltrexone. And so you're raising your immune system, you're working directly against inflammation at the tumor cells, and you're helping the patients to be able to reverse their own tumors. But not as one drug alone, but in combination with other things. Many of my cancer patients have cancer. They should all be on low-dose naltrexone because of the fact that it is helpful for them in every area of cancer therapy. Period. If I had it myself, I would be on low-dose naltrexone. And I'm a physician and a pharmacologist and a former FDA official. And I would recommend it to any and every one of my patients. It's imperative as far as I'm concerned, as a support measure. And we need to realize this. We need to realize this is not a cure. We need to realize that this is something that is an adjuvant that will help tremendously, and that when patients are in remission, it will help to keep them in remission. The fact that low-dose naltrexone cannot do any harm, and we've been showing efficacies in autoimmune diseases as well as cancer, it's something that I think the FDA is going to have to recognize this as a support measure for many of these illnesses.
A very diligent radiographer went back through all my medical notes and said perhaps we should look at the pathology of the spot you had removed from your leg 7 years ago. And sure enough, it showed that there were some suspicious cells there that hadn't been removed. So it was then decided that it was probably melanoma, and I had my lymph glands in my groin, right down my right leg, removed. And then I was having a few spasms in my right arm and my right hand. My GP, my same GP, suggested that I was just anxious about my golf swing and that I shouldn't be too worried at my age. So off I went on holiday, and while I was walking on holiday, I had the most amazing spasms in my right leg, and I knew something was wrong, thinking I'd got a trapped nerve. I went straight back to the doctor when I returned home. By the afternoon, I was seeing a neurosurgeon. He sent me for an MRI, and the result came back that, yes, I had, I think, a 5-centimetre tumour in my left side of my brain. So I had a PET scan, and it revealed I had a tumour on my adrenal gland and tumours in my lungs.
My name is Annette Manabi, and I'm a physician in Oswego, Illinois. My background is in osteopathic medicine, and I have 2 board certifications, family practice and neuromusculoskeletal medicine. I was diagnosed in December of 2014 with the cancer, and at that point, it was a stage 1 endometrial cancer, and the initial treatment plan is always surgery, which I asked to defer in an attempt to hopefully avoid surgery. And so they were willing to work with me. I said, you know, there are a lot of options that they do with women who are still trying to have children. And once you're menopausal, they just want to go straight to surgery. So I said, give me a chance to try some of these things. I unfortunately wasn't able to find a practitioner in my area who was versed in using LDN in cancer patients, and so I was having to navigate a lot of that on my own, but I worked up to the 4.5 milligram dose, and over the course of 6 months, incorporated a lot of integrative holistic treatments as well into my cancer treatment regimen. During that time, my tumor markers continued to rise, so ultimately I did have surgery in June of last year. However, at the time of the surgery, what was of note to me, and I feel a sign that the LDN and the supportive treatments I did were helpful, is the tumor itself did not invade systemically. So at the time of the surgery, it was still only a ½ centimeter into the wall of the uterus, and it didn't go into the lymph nodes, it didn't go into the circulation or metastasize anywhere. It did grow into the uterus, so the tumor itself increased in size, but not into my own tissues. And so I feel, had I gotten it sooner, and had I caught the cancer when it was much smaller, I may have had success in actually avoiding the surgery. And I'm continuing on the LDN at this point to prevent any recurrence or continue to boost my immune system, because we don't really understand all the mechanisms of why cancer occurs, and there's still a risk for reoccurrence or metastasis, and so I'm trying to boost my chances. And there's so much promising research coming out showing it is effective in fighting cancers of all types and all stages, and so I have no qualms in continuing to use it to support my own immune function.
So I went away and I followed a very strict diet then. I was very conscious that I needed to rebuild my immune system and really fight the cancer through my immune system. So I followed that for the whole of that year. In the July of that year, there was some more slight spots on my brain, so they gamma knifed it again. And then I had 7 sections of my small intestine removed.
So it wasn't until mid-2007 when I collapsed and was taken into hospital. I ended up in Hammersmith Hospital, and I had a ruptured tumour on the outside of my liver, which caused me to bleed internally, and I was very seriously ill. You know, they basically resected my liver at that stage and shut everything down, and that was the start.
So Professor Dalgleish said, well, I wanted you to have LDN anyway, because I think it's going to be good to build your immune system. He also advised me at that point to take vitamin D3, 25 UGs, high dosage every day. I was having B12 injections because I'd had so much of my intestine removed. And I was trying to drink a lot of green tea, so he put me on green tea extract at that point, which was much easier.
So it was about that time that I have an old school friend, and his wife plays tennis with Professor Angus Dalgleish, and she said, why don't you go and talk to him? He's a top oncologist. And so I did, because I really didn't know what I should be doing at that stage. So I thought, well, I've got nothing to lose. And I went and spoke to him, had a consultancy session with him, consultation. And what he did tell me, he said, look, you know, this is not quite my field, but he said, I can tell you. He said, I can't recommend it, but I can tell you that I have a dozen or so patients who are self-prescribing low-dose naltrexone for malignant melanoma, and remarkably they've been symptom-free for 18 months, and he said that's very interesting.
So here I am, just over 7 years with, I hate to say it, but at the moment, good scans. And that's really about where I am now. I suppose I love it. That's all I can say. My lungs are completely clear. And that's only happened since I took the LDN. Up until that time, they were still growing. So from my point of view, that's very positive. It's had no impact on my life whatsoever.
When I initially started taking the low-dose naltrexone, I started at 1.5 milligrams, worked up to 4.5. I'm currently still on 4.5 milligrams of the low-dose naltrexone. Initially, I did notice actually an improvement in my energy and an overall sense of feeling better. And aside from the initial disruption of sleep which took place, my quality of sleep improved dramatically on the low-dose naltrexone, and that persists. Like if I miss a night or during the surgery when I had to stop because of the pain medications, I could see a difference when I was off the low-dose naltrexone than when I was back on the low-dose naltrexone. So I find overall it's helping my overall wellness and state of health.
So following on from that, I got more information from him, and I didn't do anything about it immediately. I don't know why. I think it was because I'd been around the alternative market, and I was talking to all sorts of odd people, one of them selling mistletoe therapy.
As I consider the impact of low-dose naltrexone on myself and potential negative side effects, I did experience initially some of the sleep disruption that is commonly reported, where I was a little bit more awake at night or I woke up a little more frequently. And after about 2 weeks, that passed and the quality of my sleep actually improved. Other than that, I've not had any other types of side effects from it that I'm aware of. And in general, I'm feeling much better in how I feel, my sleep, energy, and I haven't noticed any other specific side effects.
And so I was a bit skeptical about following Prof. Dalglish's advice at that time. So I didn't do anything about it for 18 months. Anyway, within that time scale, I had 2 further recurrences of HCC, which is hepatocellular carcinoma. It's a tumor in the liver. It doesn't spread in the body, but all the same, it destroys your liver. When I came out, I did a bit more research, following up on what Angus Dalglish had told me. And I researched Bernard Bahari in New York, and I thought, well, this is very interesting, and it kind of supported what Prof. Dalglish had said to me. And I also got to know about Dr. Bert Berkson, who's in Las Cruces, New Mexico, who was doing very interesting work as well with LDN, also using antioxidants, in particular alpha-lipoic acid, and some other things. And so I based on my research, I thought, well, I've got nothing to lose, I'll give this a whirl.
I have, in terms of ways to take the low-dose naltrexone, I'm taking the capsule form that I obtained from a local compounding pharmacist. In terms of the future of LDN in the U.S., I think, in the ideal world, I would wish that all the major cancer centers would incorporate it into their treatment regimens immediately. Unfortunately, change in medicine is very slow and it's challenging, and because it's already a patented medicine, there's not a lot of profit to be made. It's inexpensive, and so that becomes a barrier. I think in realistic means, the integrative medicine and holistic medicine community will be embracing it as the word gets out, as conferences are held. They will be the ones to hold the torch and get it available. As the patients also demand access, it'll be, I think, through that population of physicians who offer it to their patients. I would like to see it as a front line for anyone who's got a suspicious diagnosis that's potentially cancer. They should be started immediately.
So I started, without any expectation, I started taking the LDN, and hey presto, miraculously, I went into remission for 3.5 years. 3.5 years, and that in itself was remarkable. And I was being treated then by someone at Hammersmith Hospital who was a bit dismissive about LDN. He'd never had great faith in it, and what he said to me was, he said, look, your liver's recovering. I don't think your recovery and your remission has anything to do with this low-dose naltrexone you're talking. So he was so dismissive, I discontinued it, and I rue the day I listened to him, basically. So I discontinued it, and then within 9 months, I'd had another recurrence of another tumour in my liver. But after I had this news, I decided I'd go to America to see Dr. Bert Berkson, because I'd heard about him, and I thought, well, I'll go and talk to the guy. So I went out there and started on the LDN again with him, and I came back to the UK, again with no expectations, and when I got back to the UK, I'd only been on the register, the liver register, for 6 weeks, I think it was. And I was just sitting at home one day, and I had a phone call saying, we've got a liver for you. And I almost fell off my chair, and we had to make a sort of an instantaneous decision about where to go. So I said yes. Interestingly, when they removed my liver, replaced it with a new one, when they sectioned the old one, they said, oh, that's interesting. All your liver cancer has disappeared. Your tumour has completely necrosed. So I don't know how to explain that, but and since that day, that was over 3 years ago now. So, well, I shouldn't really judge, but I suppose in my mind I know that what did LDN do for me? Well, it gave me 3.5 years of remission from the time when the doctors were virtually saying, look, he's going to have another recurrence in 3 months' time, and it doesn't look very good, to basically getting me through that period. It's gone very well indeed, and no recurrence of any sort. So do I believe in LDN? Yes, I do. I know it worked for me.
So more commonly, we are getting many inquiries from patients who have been diagnosed with various types of cancer for low dose naltrexone. And it's quite important that if you are going to look at using the low dose naltrexone for your cancer therapy, that you talk to your individual GP and your oncologist first, because you may be on certain types of pain medication which are contraindicated initially unless they're very carefully handled. So you should really never go. A lot of people have come to us because they've gone onto the internet and they've found something, or they found tablets that they can buy on the internet. A lot of those are not real, or they're fake medications which are dangerous, and you should not randomly decide to treat yourself for cancer by buying naltrexone tablets on the internet. I know it sounds very simple, but we find a great number of people who do that. So looking at the possible side effects you can have from taking LDN along with cancer chemotherapy, that's extremely individual dependent upon the type of cancer chemotherapy that you have. So, for example, there's a growth in biologics and vaccines versus original chemotherapy drugs like the platins and things like gemcitabine, which have a slightly different mechanism of action. So if you are taking or you've been prescribed many different types of cancer chemotherapy drugs, each individual cancer is specific. Cancer is not one disease. There's multiple different types of treatments for different types of cancer. And the guidelines are always changing. So there are biological drugs, there are chemically drugs called the platins, and there are also drugs which change your immune system, like vaccines. So it's going to be very individual when and where you're able to take LDN in your treatment cycle or your treatment pathway. Now, there has been some information that we are aware of which has not yet been released, a couple of papers that are looking at the use of low-dose naltrexone along with cannabinoids in a pulsed way, and I think over the next year we're probably going to hear more about that, along with vitamin D. So I would certainly say if you have been diagnosed with cancer and you're looking at using LDN, the first thing you should do is start taking vitamin D. And the dose for that you can decide with your practitioner, but really we'd be aiming between 5,000 and 10,000 units per day. LDN seems to work much better when it's being used with that. But LDN itself should not be taken when you're on any strong painkillers without direct medical supervision. So speak to your doctor or pharmacist before embarking upon this journey, and make sure that you get someone very qualified who is capable of reading the most recent research and keeping you up to date, and make sure that your treatment pathway works as well as possible.